Hello, everyone, and welcome to our live stream, Mental Health in Older Teens and Young Adults. I'm Ed Bottomley with the Michigan Medicine Department of Communication. Today, we're going to be talking about the early detection and treatment of psychosis, a mental health state in which people see, hear, and sense things that others do not. This is the last of our 4 live streams on mental health topics that we're doing as part of Mental Health Month. Today's panelists include 2 experts from our Department of Psychiatry, Dr. Ivy Tso and Dr. Stephen Taylor. Dr. Tso is a clinical psychologist who serves as the training and clinical director for Michigan Medicine's Program for Risk Evaluation and Prevention, or PrEP. That's a clinical and research program for youth with early signs of psychosis and serious mental illness. Our other expert, Dr. Taylor, is a psychiatrist who directs the PrEP program and is the Associate Chair for Research of our Department of Psychiatry. The team that they lead includes mental health practitioners from many disciplines who help patients and their families get the care and support they need for what can be a very daunting, even frightening diagnosis. They also offer multiple ways for people with conditions that involve psychosis to be part of the search for understanding and new treatment options by volunteering for carefully conducted research studies. We're really glad to have both of you here, Dr. Tso, Dr. Taylor. And before we start, just a few housekeeping items for our audience. You can submit questions at any time for our panel to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can send us a private message, or you can email us at ask-mishmed@med.umich.edu. That email is a bit of a mouthful, so one more time, ask-mishmed@med.umich.edu. If you can't stay for the whole chat, or you want to share the recording with a friend, a video of the chat in its entirety will be available on our Michigan Medicine YouTube channel. So let's kick things off with the most basic question, which perhaps isn't at all that basic. What is psychosis?
So
Go ahead.
I'll tackle that one. First of all, thank you, Ed, for hosting and having us here so that we can spend some time answering some questions and hopefully educating people a little bit about things like psychosis and early psychosis. So yeah, you're right. Psychosis and the question of what is psychosis can immediately become somewhat philosophical. We often refer to it as like a failure of reality checking, or which is a way of saying that the way we all construct our models of the world, what we kind of consider our reality, and usually we share with other people so that we can communicate and live our lives. And that ability to kind of make those internal models, if you will, breaks down. So it's a failure of kind of these integrated functions. Now, that still is kind of abstract. And I think what people really experience are things that you alluded to earlier, Ed, which is perceiving things that are not there. Typically, that takes a form of hearing things, hearing voices that are not there. Early in the phase of psychosis, this can be someone might complain about hearing whispers or something, and they may have some insight into this being not real, which is not fully psychosis, but it can be the beginning phases of psychosis. So perceptual distortions, again, the hearing or seeing things that are not real. The other kind of component is around beliefs. And so people will believe things that are just out of sync with other people's beliefs in their community. It's important to think about what the community is, what the community believes, because what happens with beliefs that we call delusions are that these are really out of sync. Very frequently, they take the form of paranoia, feeling that others are trying to harm them, feeling that there's a plot against them, feeling that they're being monitored. They can also take the forms of believing things like their thoughts are monitored or rather heard by others. So, and then the other kind of form of psychosis that we see is around disorganization in terms of how people have, people will complain about trying to organize their thoughts, or they will say things that kind of don't make sense. They'll say things that seem very nonsensical. So that the ability to kind of organize the normal kind of flow of thoughts, it gets interrupted. And people will often complain about not being able to attend to things, and that things don't seem right. They talk about some sorts of confusion about things that should not be confusing to people.
Thank you for that. Anything to add? Go ahead.
Yeah, so I want to add that psychosis is a core symptom and most commonly seen in schizophrenia, but it can also be present in other psychiatric disorders like bipolar disorder or major depressive disorder, post-traumatic stress disorder, or autism spectrum disorder, and borderline personality disorders. So it's basically, you can think of it as like a general symptom, almost like fever in an illness, right? It's non-specific itself, but it can be indicative of a more severe mental illness. So that is something that when it emerges, then we need to take it seriously.
Thank you. Thank you both for that answer there. Let's move on to our second question here. What age range is most likely to start? And why is it so important for young people and parents, teachers, medical providers, law enforcement officers, and others who work with young people to know about it? So again, what age range is it most likely to start?
So maybe I can take this one. So the most common age range that psychosis emerges is adolescence and to young adulthood. And oftentimes I would say 14 years to 30. Sometimes this can be younger, sometimes it can be older than that, but I would say 14 to 30 is probably the most common age range. And the reason why it's important for young people, parents, and people who know them, who work with them, to know about this is a psychiatric condition that's very disruptive to daily life, right? And to disruptive to the young person's important milestones. Especially you think about 14 years old, right? You're in high school or going to college, and these are the periods that people actually, make strides in their personal life, making relationship, academic achievement, their first jobs, right? If the psychosis emerges, then it can be very disruptive. And oftentimes the signs actually are noted by people closest to the young person, like the parents, the family members, the teachers, counselors, or medical providers. So it's important that if we want to detect that early, then we need to make sure that the community, not just the patients themselves, right, but the entire communities involved are aware of these symptoms.
Thank you. Thank you for that, Dr. Tso. Now, the next question, there's a related term that people might hear or perhaps use often, which is psychotic, and which is often used to mean someone who is perhaps unhinged or acting in a threatening or violent manner, or just someone acting very strangely. Can you talk about this word and the way it might be used in medical ways compared to how we might hear it used every day?
Well, I think you kind of illustrated nicely that we do use that term in casual conversation, non-medical, to describe behavior that's kind of outside the range of of normal behavior, and that's in the sense that psychosis in the medical sense is behavior that's very deviates from normal behavior. It kind of makes sense that those two terms there'd be some overlap between that kind of common use of kind of psychotic, crazy is another term that gets used. I think it reflects the fact that when we're dealing with a severe mental illness or syndrome, really like psychosis, it's something that kind of falls outside the range of what people expect and what people are comfortable with, and it's very uncomfortable for people to see someone who is has this broken reality checking, who is experiencing the sorts of things that others don't share, delusions that are very fixed and that affect their behavior, and the parents, loved ones can't understand why their son or daughter has these bizarre beliefs. So it's very disturbing for people who have a loved one who is experiencing something like that. And in that same kind of sense of meaning, that things that bother us or that we think are crazy, just outside the range of what we accept, which of course doesn't, a lot of those things that people, when people use that term, this is not a medical diagnosis. It's just kind of a casual term that has that similarity of being outside the bounds of kind of normal behavior.
Thank you for that. I see you nodding, Dr. Tso. I don't know if you had anything to add. So let's move on to our next question. If someone starts to hear voices or see things that aren't there, or perceive things or reactions that aren't grounded in reality, does that mean they have a specific mental health condition, or are there multiple mental health conditions that can include psychosis as a symptom?
Yeah, so this is a great question. I guess I slightly touch upon this like earlier, right? Like it's a general symptom is you cannot really just judge by itself to make the diagnosis. You need to take a very careful a history of the person and consider all other symptoms as well, because psychosis can be present not just in schizophrenia, but by a number of other psychiatric conditions. And I also want to add that just because someone hear voices or see things that are not there doesn't mean that they even have a psychiatric a disorder, so to speak. In fact, research has shown that in the general population, some people, actually a good proportion of them, would have this kind of experience semi-regularly or regularly. I think the major thing is that we need to assess if that negatively impact people's life. When that happens, then we will see more it as a disorder and try to help them.
Yeah, thank you for that. I don't know if you had anything to add, Dr. Taylor.
Yeah, no, I think Dr. Tso makes a very important point. And I would add, it's something that we've only come to appreciate in the field of psychiatry, really in the last couple of decades. When I did my training, which was more than a few decades ago, we really didn't kind of understand or accept that this was the case, that people could have experience of voices of people not being there, or some types of delusions, and be perfectly functioning members of society without any kind of distress or reason to seek treatment, because they're, for some reason, they're able to have these experiences that do not affect them like those people who have what we would call a diagnosable mental illness. So it's something that, as I said, is something that we've more recently come to kind of recognize as another dimension of human experience that we really don't have a very good grasp on.
Thank you both for that answer. The next question that we have, it's about your clinic, which is called PrEP for short, and it focuses a lot on early treatment of psychosis, especially in young people. My question: why is this so important?
So it's important for a couple of reasons. One is just because that's what the psychosis, the medically, the disabling psychosis most often appears, as Dr. Tso mentioned. So in that second decade of life. But the other thing that's really important is that there's a lot of good evidence that intervention that occurs early, as soon as these symptoms start to appear and disrupt a young person's life, that intervention early has benefits in longer term outcomes. So that if you can get in and help a person, when they're first starting to experience these symptoms, the chances that they'll do better they're elevated. So for instance, we call this the duration of untreated psychosis. That is the period between when the person starts to experience symptoms and when they actually get treatment. In the United States, it's about 3 years. Which is way too long. The recommendations of the World Health Organization and other medical psychiatric societies are that this should be less than 6 months. And so there are a lot of programs, and PrEP is one such program, but programs worldwide that are making efforts and doing things to try to identify people in these early stages. So doing some outreach and a lot of education, that's very important to let people know that these symptoms can occur. And then also they're actually, quite treatable. When intervention occurs early, the majority of people who have these symptoms get better and can go on, graduate from high school, college. Not all the time, I should say. Sometimes the illness can be more serious, and that's something that we've known for a while about, particularly diagnosis of schizophrenia. But there are many people who have that diagnosis and can go on and do actually quite well in life.
And I want to add that the reason we want to intervene early is that a lot of research data has shown that like the more relapses or episodes that the person have, it can actually permanently change the brain function and the structure. And that is something that we might not be able to reverse, right, with treatment later on. Obviously, as researchers, we are trying to develop better treatment options, even for people with chronic psychosis. But the hope is really in the earlier phases, so that's why we really want to focus on the early treatment of psychosis.
Thank you. That neatly describes why this is so important. My next question, if someone is concerned that their child or friend or relative or co-worker or they themselves might be experiencing signs of psychosis, what's the most important thing to do and who can they reach out to? So
there are a number of these clinics around the country that focus on early psychosis. The NIMH also has a website that provides information about the clinics that specialized in first episode, or this is really referring to the early treatment. So that's one source, is to go online, look for the clinics that are in your area. Psychiatric treatment, and particularly for psychosis, is very local. It's unlike, say, some forms of cancer treatment where people will travel many miles, across the country to get treatment. That's less useful with psychotic disorders, psychiatric disorders, because the treatment is really occurs over a long time. So it should be something that is in a person's area. And as I say, there are more of these programs popping up. Unfortunately, there aren't as many as we need. I wish I could say that we have good coverage across the country for early psychosis, but the sad fact is we do not. Even in our prep clinic, we have far more people who want to come see us than we can actually reasonably and treat well. And so it's something that is an area of definite need for our society to provide more resources and more access to treatment for people like this, because as we've just said earlier, it's really important to intervene early and really get that treatment out to help folks.
Yeah, so obviously Google is your friend, right? But when you Google things, it can also return a lot of results that are not so helpful and overwhelming. So in addition to trying to find out these specialized programs, I would advise people that if they notice some symptoms or behavior changes in the friends or family members, reach out to the teachers or the school social workers or the primary care providers, right? Because oftentimes they will know more who to reach out to. Because we prep clinic, we have a lot of relationships with community providers and school social workers, etc. So they will be able to connect your family members to us.
Yes, thank you. Definitely worth pointing that out. And now we've touched on this a little bit, but let's drill down with this question. When does psychosis become an emergency that needs immediate attention?
So,
go ahead.
Sorry, I froze a little bit my internet. Sorry about that. So when does it become an emergency? I would say there are different definition, right? When you think of it as when you need to take the person to the emergency room, right? Really need immediate medical attention is when their behavior, they are not able to take care of themselves, or they are in dangers of harming themselves or others. Steve, do you have anything to add?
Yeah, I think that's pretty much, those are the key points. Sometimes a person will be, they won't clearly be, talking about hurting themselves or more rarely hurting other people, which is, as I say, pretty, generally pretty rare in our experience. But what often occurs is that there'll be withdrawal. A person will not be eating. They won't be doing usual activities, and they'll be exhibiting odd behavior that is, and maybe reluctant to actually go to see a doctor, to see a clinician, because sometimes the voices, may be telling them, don't do this. The voices may be telling the person, not to allow the treatment to be offered and are taken. And so in situations like that, where they're really just, again, not taking care of themselves, but really they're not functioning. And so, then, taking and having an evaluation done is important. And I would add, and unfortunately, we sometimes need to fall back on this, but if a person is doing things or not doing things that put them in danger, so not doing things like, it's winter in Michigan and they're walking shirtless, at 5-degree weather, and that's putting themselves at risk. And so in situations like that, for people who will not come in to get treatment where it's clear that they are endangering themselves, then there are mechanisms. The police may need to be called to bring a person into the emergency room to get treatment. And so there is that mechanism of having people come in, bringing them in. Because of their illness, they won't have the insight, and so they won't, agree. But because their minds aren't working correctly, we really need to not think about, trying to follow their wishes, because their wishes are distorted by psychosis, and they're putting themselves in danger. So that's what we call that process civil commitment, and it's sometimes necessary, unfortunately.
Yeah, thank you for that answer. Thank you both. The next question we have up, we've had some questions coming in from our audience members, one of whom has a relative who occasionally has psychotic episodes, but returns to normal between. Does having such episodes always mean that someone is going to have a life-altering, serious mental illness, or could they have a better prognosis than that?
That is a really good question. It often depends on what is the underlying diagnosis associated with the psychosis. For example, when we see in mood disorder like major depressive disorder or bipolar disorder, they often also come with some psychotic features during the mood episodes. When that's the case, those psychotic features seems to be come and go together with the mood symptoms, and oftentimes that kind of illness courses seem to have better prognosis than more chronic psychotic symptoms.
Thank you for that, Dr. Tso. What do we know about why psychosis happens? Is it genetic, the result of stress, or other triggers such as drugs or loneliness, related to other mental health conditions perhaps, or something else?
Yeah, that's the question that we spend a good deal of time trying to answer in our field. So we know certain things. We don't have the final answer, but we know, for example, that mental illness, psychosis in particular, does run in families. So there is a genetic or an inherited component. To give you an idea of that, it doesn't tell the whole story. So to give you, if you take identical twins, so identical twins have the exact same genetic composition, the exact same genes, which is why we call them identical. If one twin has schizophrenia, there's only about a 50% chance that that other twin will also have schizophrenia. So that's a good way of kind of looking at the contribution of genes versus an environment, because the two twins have the same environment and they've got the same genes, but they don't both have the illness. So there are a lot of other factors that occur besides those that you inherit from your parents. There's also, I should say, the genes that contribute or set up this vulnerability to schizophrenia. There are many, probably hundreds, if not thousands of genes. There's no single gene in general. Now, there may be some what we call rare variants, which are kind of like syndromes that are not quite schizophrenia, but for the most part, what we see is a combination of many genes. So what happens after you get that vulnerability is really not clear. There are things that we've identified, stress that begins with pregnancy or delivery, that obstetric complications are associated with higher incidence of schizophrenia. Time when you're born, or early spring births have a slightly higher incidence of higher risk for schizophrenia. Stress, early life trauma, another thing that sets one up and increases that vulnerability to develop psychosis. In the onset of psychosis, it's kind of controversial whether or not stressors, actually cause the beginning of psychosis. They probably will trigger something that's already there, but they don't cause, that is acute stressors. So something that, a person experiences a trauma, when they're in their teens, if they develop psychosis afterwards. Unlike post-traumatic stress disorder, where we do attribute that disorder to the trauma, in schizophrenia, we would say the trauma triggered something that was already there. So it's not a disorder or a disease that's caused by trauma in that sense of, that's why it occurred. But there are other things, there's theories that involve, inflammatory processes, processes where the autoimmune processes may be involved. That's where the immune system of a person attacks their own organs. There's a lot of illnesses that are like that. Some of which involve the brain. But these are all, it's not exactly speculative because there's some data to support this, but it's just really a lot of different causes that converge and contribute to a person actually developing psychosis. But the bottom line is, as I said, that we really don't have a good firm grasp of what actually causes it. But I think we can say that there are many things, many factors that cause it. And one analogy that I use is Dr. Tso mentioned, psychosis is kind of it's a final common pathway, as we say, meaning that you can get to it in a lot of different ways. And congestive heart failure is kind of like that. Congestive heart failure, where the heart doesn't pump enough blood to the organs, has a lot of different causes. Now we know more about those causes than we do about the causes of psychosis, but I think the analogy is fairly apt.
I want to add that Ed, you're very on point about one of the factors could be loneliness, right? That is chronic stress by itself when you think about that, and it's particularly poignant in the past couple of years with the pandemic going on. People are isolated, and we have seen more research data coming out that loneliness is actually predictive of more psychiatric symptoms in young people and people with schizophrenia as well. So I think that's definitely one of the things that we need to address as society, right? How to help people to feel more connected.
Yeah, thank you both for that. And I think that the next question really nicely flows on from this. What are the most urgent research questions you and other teams are trying to answer to improve detection and care?
There's so many aspects. I think Steve and I do very similar research, right? We are very interested in the brain, how brain mechanisms, contribute to the risk and the development and the treatment response of schizophrenia and psychosis. And that's definitely something that can help us to develop more targeted, more precise treatment, right, for each individual. So that is basically the majority of my research program is about. But I think other areas that we urgently need to understand is like the social environment, right? Because we cannot just target the individual itself. The brain is not just one person's problem. When we talked about rehabilitation or recovery, it takes the whole village. And how can we improve the system, the social environment, to help our young people to recover?
Yeah, and I would just add to that, one of the important parts of treatment, which in PrEP, treatment is a comprehensive approach. We use a combination of medication, psychotherapy, group therapy, skills training. So there's no kind of one thing that needs to be done, but medications is usually a pretty important part of that. And in some cases, medications, and it's a shame, but medications have been taken as like the only thing important, which is a mistake in our opinion. But what I would say is that it is really important to develop better medications. The ones we have work pretty well. As I said, a good, over half, 2/3 of people have a pretty good response, but they also have some bad side effects. They have, associated with weight gain and potential, risk for diabetes. There can be some movement disorders that are associated with the usage of some of these medications. So it's definitely a trade-off that we encounter when we use them. We think that it's still a trade-off that favors using the medication because of what they can do to prevent symptoms. But we need better medications, ones that don't have this particular trade-off, and that work more to target some of the symptoms that we don't have we aren't able to treat as well. There's symptoms that we call negative symptoms, meaning that they're negative, meaning not just that they're bad, but that they're the absence of, and what they are is the absence of affective relatedness, the absence of kind of social engagement, the absence of kind of being able to have fluid conversation. So those kind of negative symptoms, our medications do not treat very well. As a matter of fact, sometimes they make them a little bit worse. So medications that can work, and the other thing I would mention is that cognition is impaired. When you have a disorder like schizophrenia, and the medications, again, they do a little bit to improve kind of overall attention and focus, but they don't really get at that core symptom of cognitive impairment or inability to focus and carry out complex functions, particularly some of the things that we're interested in, Dr. Tso's research in particular, the area of social cognition, which is really how people perceive and understand the social emotional life of those around them. Absolutely critical knowledge that we tend to undervalue sometimes. I think there's been more recognition of the importance of it, but it's definitely affected when people have schizophrenia. And so that's something that we need better treatments for.
Thank you. Thank you for that. The next question that we have are, I understand that some of your research involves advanced MRI scans. Can we actually see psychosis happening by scanning the brains of people with this condition?
I would say that MRI scans can reveal brain activation patterns related to cognitive processes or symptoms in psychosis. It can tell us how the brain networks affected in psychosis, give us some clues, right, to develop more targeted treatments. But right now, the technology that we have can reveal this average as a group, right? So we can compare people with psychosis with people who don't. Then we can tell the group differences. But you can't really do it at the individual level, like scan someone's brain and then say, "Yep, you have psychosis." We cannot do that.
So that's very interesting. And sticking with you for a second, Dr. Tso, you referenced earlier something that an audience member also asked about in an email at the start of our discussion. And perhaps you can go into a little bit more detail on this. They asked, does having psychosis or a serious psychotic episode damage or alter the brain physically?
It can, and research has shown that some brain structure, right, or gray matter volume can actually reduce as the person has more chronic schizophrenia or more episodes. And I think Steve can also add to that, because that is a research area that he's very familiar with as well.
Yeah, the damage is subtle, but it does show up in studies that look at tens or really hundreds of patients, and there are various networks, as we say, that show themselves to be misfiring, dysfunctional. Various at the molecular level, there are abnormalities that have shown up that involve different neurotransmitter systems, and so yeah, we do see things that mark the psychosis, but again, not definitive. There's this overlap Dr. Tso referred to, so we don't have any what we call a biomarker, meaning that a test or an imaging study that we could use to diagnose and say, we can look at this person with this test and say, you have schizophrenia or you do not have schizophrenia. We're not there yet, but yeah, there does appear to be a worsening effects of what we call chronicity. So you have the illness for a longer time, and more of these damage shows up.
Thank you. Thank you both for those answers. The next question up, we really can't have this conversation without acknowledging that many people may be wondering if the perpetrators of recent mass shootings in Buffalo, in Texas, and Oxford, Michigan, among others, have been experiencing psychosis, and if that helped lead to their violent acts. What do we know about the likelihood that someone with psychosis will act in a violent way? And conversely, what do we know about the likelihood that a person who commits a heinous act might have psychosis?
Yeah, well, I'm glad you asked that, because it is a very important question. And I can certainly see where it comes up, because we're talking about kind of casual definitions of psychosis. People see they see a crazy senseless act, and we're talking about psychosis, and it's colloquially referred to as crazy. So people make the equivalence: crazy act, crazy person. That's way off the mark. So people with psychosis are more likely to be victims of violence than perpetrators. Violence, people do have, their violence does occur at a higher rate. There's particularly some, they tend to be more like, outbursts, physical struggles, but they tend to be more impulsive. There are the recent examples of that I think about, like a couple of incidences that have happened in recent years, and subway incidences where a man, I believe, had the diagnosis of a psychotic disorder, pushed someone off the subway platform. Tragic sort of occurrence. But that kind of impulsive violence is, if we do see it, and it's quite rare, that tends to be what we see. The violence connected with mass shootings, from everything we see, involves planning, deliberation, premeditation. This is not the violence of psychosis. This is very different from what we see with psychosis. So the question may be, well, is any mental illness involved in these cases? Because they're obviously very disturbing, and we're disturbed by them. And so there's kind of this natural tendency to say, well, the people are disturbed. This is very problematic. I'm disturbed personally to hear someone like Tucker Carlson, who the other night said that the Oxford shooter, not the Oxford shooter, he said the Buffalo shooter and the Texas shooter all had mental illness. I and Tucker Carlson had approximately the same information and access to. There's no way that he can say that. Also, that is the height of social irresponsibility for someone with his platform to make a statement like that. It's stigmatizing people with mental illness, and he has no basis to say that. And it really, as I said, it's very inappropriate. As a psychiatrist, I can't make that diagnosis. And so the fact that a pundit like him should say that is really off the rails. And I'll go on and say, because you asked, Ed, that the question about mass shootings, this is not a mental illness problem. This is not just mental illness. And the reason why I say that is because rates of mental illness in the United States are pretty comparable to other countries. If you look at a proxy for mental illness, which is adolescent suicide, we're in the upper third tier, but we're right next to countries like Canada and Australia. When you look at mass shootings, particularly in schools, we are outliers. We are way beyond any other country. So to say that these shootings are mental illness problems, when that is just really misleading. We really need to look at other factors that are not just mental illness. Now, this is not to say that people who commit these acts are not troubled, but I think many of them are troubled in ways that adolescents who break up with a girlfriend are troubled. They do impulsive things. They're adolescents. Their brains are not formed. Their brains are not formed until they're in their mid-20s, which is why people don't where we have laws against alcohol purchase for those under 21. It's why rental companies will not rent cars to people under 25. And yet, and this is the real tragedy, I think, these shootings, is that yet we're in a society where these would have been preventable if we would do something as simple as not selling high-powered assault rifles to 18-year-olds. I'm sorry, this is where a little bit off target here, but I think it's relevant because there's been a lot of news about, there's a lot of discussion and a lot of really wrong discussion, as I alluded to earlier, that this cannot be foisted off on mental illness. Now, we do need better mental health treatment. It's definitely an issue, definitely a problem amongst our youth and our adolescents, not just for psychosis, but to see that as a solution to mass killings is a form of insanity, if you pardon my expression.
Thank you. Thank you very much for that, Dr. Taylor. Dr. Tso, I don't know if you have anything to add on that topic.
I asked Steve to answer this question before because I don't want to. I was afraid that I might lose it. It's just like it's just we need to stop scapegoating mental illness in this kind of mass shooting.
Thank you. Thank you both for that, for the answer to that. Dr. Taylor, thank you. That was a good detailed answer on that. Pivoting off a little bit, you've touched on medications and other therapies that are available for people with psychosis. Do many people get help from the first one they try?
So as we say, the response rate is actually pretty high. At least 2/3 of people get pretty decent help from antipsychotic medications in stopping voices and reducing or eliminating delusions. So the response rate is quite high, but there are those, a good 1/3 of people who do not get that initial benefit. They can sometimes, with additional medications, or I'm assuming that people are getting the adequate treatment with the proper dose, but with additional medications. There are one in particular that does work a little bit better than the others, and sometimes people, this is called clozapine, can get a response to that where they don't respond to the others. In general, the medications have about the same kind of level of efficacy. We switch medications because they are very different in terms of side effect profiles, and people have different reactions to side effects. And so that's the main reason for switching the medications, because the side effects can be very annoying, and there are major reasons why people stop taking the medication. We also, the proper dosing is important. A lot of people are overdosed. They're on too high a dose, and they have side effects that they don't need to have because the medication is not being properly administered or properly dosed.
So I'm a clinical psychologist, so I can speak to a little bit more about psychological treatments available for people with psychosis. And there are multiple different psychotherapies available, have been shown to be effective, especially cognitive behavioral therapy. And that is one of the therapies that we provide in the prep clinic. And it, as Dr. Taylor said earlier, right? Like the medications, it's very helpful, but sometimes the side effects can be the major issues that prevent them from being compliant to treatment or adhere to the treatment recommendation. So connecting them with a therapist to work through the issues and other things that are affecting not just the symptoms, but how they connect with people and how they function in school and live independently. Those are major goals that people want to work with. So psychological therapies are actually very helpful in that area.
Thank you. Thank you both for that. And we have an audience question which kind of dovetails nicely about medications that might be used to help someone who is hospitalized for a severe psychotic episode. And the question reads, can these also be used after a hospitalization to maintain their mental state?
So I guess I'd have to kind of see exactly what the medication is. the person's referring to. But I can, in general, people are started on antipsychotics when they're hospitalized, and they are continued on those antipsychotics as long as they're tolerating them okay in the hospital. So that the answer to that, the short answer is yes. But they're also given other medications to calm them down. They're given what we call benzodiazepines. So those are medications they're kind of sedating. They actually do help the symptoms sometimes, and sometimes we use them as in the outpatient setting. But a lot of times those medications are used just in the hospital setting, and then they're discontinued when a person leaves the hospital. So some of the medications do not continue, but the kind of the primary medications are antipsychotics for during hospitalization, and those definitely will continue. I should add that also sometimes after hospitalization, side effects may take a while to kind of kick in, which is due to the levels kind of building up over time. And since many hospitalizations are pretty short, 10 days, 9 to 8 days, and sometimes those side effects can pick up a little bit more after the hospital. And so the outpatient prescriber needs to make some adjustments because the side effects can be very, as I said, annoying and very sometimes debilitating too.
Thank you for that. And then, a third question that actually dovetails nicely. How hard is it for someone with psychosis to stay on their medication and engage with their treatment long term? What can happen if they don't?
I guess it depends on who you ask. Amongst the people who I'm working with in my clinic, some of them find it relatively easy, and they are grateful that they have a medication and they've got a treatment regimen and they've got therapy that's helping them get along and do well. Other times it's a big challenge, and the side effects that I've mentioned are a big reason why. Another reason is that when you're a young person, when you're 17 and you have this huge disruption to your life, you've maybe embarrassed yourself amongst your friends because of the things you did or said when you were psychotic. So it's the sort of thing that is very hard to kind of come to terms with, particularly as people kind of if they come out of an episode, so they regain that the intact reality testing, and then it can be hard to kind of reconcile what they just went through. So there's a lot of times where people will reject and fight the diagnosis. So they'll reject the medication, not because of the side effects, but because they don't want to have an illness. They don't want to take the medication. They don't want to think about having to take the medication for a long period. And we don't have good data to be able to say you need to take this medication for 10 years or 3 years or a lifetime. It's one of the areas that I wish we had much better knowledge about to kind of tell people how long to take the medication. But if it is schizophrenia, this is an illness that some people recover from, but most need to actually continue taking medication or getting some sort of treatment, for the duration of their life even. So it's hard for young people to be thinking about that and looking into the future and, not wanting to have the illness. I mean, I wouldn't want to have this illness. No one wants to have this illness. And so that's oftentimes motivating people to that frustration and that denial is a big part of, early treatment and trying to help people come to terms with it is what we need to do as we administer treatment.
Yeah, that's why for the treatment for early psychosis, we should not focus on just medications, right? But the psychosocial piece is very important to engage the person and form, strong alliance with the family and the patients to appreciate, the psychological loss, right? And to come to terms to accepting this illness and to develop skills to cope with it.
Thank you. And just a quick time check. We've got about 10 minutes remaining. I can see probably about 5 or 6 questions. I'd love to squeeze those in. The next one reads, for people with psychosis to complete their education, hold jobs, raise families, participate in their communities, what kind of support do they need and where can they turn?
Yeah, this is a great question. As I said, like most often we will connect the patient with like medication management and psychosocial therapy support, right? But in addition to that, these alone are not sufficient to help them to really recover, right? Because they need help to with their school. They might need some accommodations with school, or some helps with like searching or interviewing for jobs, right? And how to manage the interpersonal relationships. So these are the supports that are needed, and that's why the early psychosis programs like PrEP, like we are committed to provide this kind of support to we call it like a wrap around approach, right? To not just treat the person as a biological being, but also provide this kind of support.
Yeah, I could just add to that because I totally agree with Dr. Tso on this, and this is why we work together. But what is really, really frustrating is that the evidence that these programs are called coordinated specialty care work is very strong. Insurance companies are very reluctant to pay for these sorts of interventions, which is really a shame because it's a lost opportunity. It's really consigning people to much worse outcomes than they would otherwise have if we would be able to get these services, get reimbursed for the services, because they're not cheap. They involve highly specialized individuals, therapy sessions, training sessions, people, job coaches, people working in schools. So it requires an investment, and it requires society to be able to say this is important, and we're going to mandate that it gets funded. But of course, we don't have that. But we should.
Yeah. Thank you both for that. Well, let's move on to an audience question, slightly off topic. We've been mostly talking about young people and psychosis, but we had an audience question about an older person who appears to be experiencing delusions and hallucinations. Can you comment briefly on psychosis in older age and how someone could get help for a loved one experiencing it?
Yeah, well, it's the question, the direction to refer to to see a psychiatrist, a specialist. There are not the older person psychosis clinics like there are early psychosis clinics because it's a rare condition. We don't see it as often. It's unusual to see the onset of psychosis after the age of 30, but it does occur. One of the things that first of all, one needs to look at is this an affective disorder, meaning something like bipolar disorder or depression that has psychosis as a part of it. So thinking about looking at the diagnosis, it's maybe not as likely to be schizophrenia. The other thing that's important to think about is various dementing processes, because particularly as people get older, there are some conditions that dementia conditions where psychosis is one of the early signs. And so, having, cognitive testing, having brain imaging done is very important if a person is developing psychosis, past the age of 50, say. So that's one thing to think about. There are, metabolic conditions that, thyroid conditions, vitamin deficiencies, that also can cause psychosis at later ages. And so a good medical workup is important in a person who has a late onset psychosis.
I want to add that, even though most new incidents of psychosis happen earlier in life, right? But for women, there seems to be a small spike post menopause. So that is something that we have noticed, but we don't understand very well. Seems like the National Institute of Mental Health is trying to give out grants to research grants to understand the area.
Thank you for that, Dr. Tso. And lastly, we can't have this discussion without talking about a topic that's very distressing, but very real, and that topic is suicide. And if this topic might be distressing for some of our audience members, you may want to silence your volume for the next few minutes. Fast forward if you're watching this as a recording. My next question, are people with psychosis more prone to suicidal thinking or to attempt or complete suicide?
This is Unfortunately, true. If you think about some of the symptoms of psychosis, right? Some patients might hear voices that tell them things to do or say very negative things to them, and which is very distressing if it goes on long term, right? So, unfortunately, suicide is at higher rate among people with psychosis than the general population.
Thank you for that, Dr. Taylor.
Yeah, I was just going to add, but there is help. Suicide hotlines are there's more of them around. Obviously, if a person is already engaged in treatment, they should know that they can always reach out to their treater. To sometimes we frequently set up safety plans so that people have plans in place if they do have suicidal thoughts start to trend into urges and start to trend towards maybe potential acts. So there is a lot of things that can be done, but it is, as Dr. Tso said, unfortunately, there's a very high rate of suicide in people who have psychosis, and it's something we pay attention to and worry about all the time.
Yes, and you're absolutely right. The National Suicide Prevention Lifeline, 800-273-8255, or you can use the chat function on their website, suicidepreventionlifeline.org/chat. That's suicidepreventionlifeline.org/chat. We also had a question about psychosis and chronic traumatic encephalopathy. Is there anything you can add about that? And did I pronounce that correctly?
So other than to say yes, psychosis is occurs for a lot of different syndromes, and chronic traumatic encephalopathy can be one of them. I admittedly do not know that area very well. It's not something that we have seen a lot of, but there are definite reports, and there is a higher incidence of psychosis for people who have CTE.
Thank you. Thank you both for your time, and thank you to everyone for joining us today as we mark Mental Health Awareness Month. If you'd like to share this video with anyone, you'll be able to find it on the Michigan Medicine YouTube channel and Facebook page at any time. The PrEP Clinic for Early Evaluation and Treatment of Psychosis has a website. You can find it at mishmed.org/prep. If you or someone you know needs immediate mental health crisis support, please contact the National Suicide Prevention Lifeline. Again, that number is 800-273-8255, 800-273-8255. You can also use the chat function on their website at suicidepreventionlifeline.org/chat. We really appreciate our experts' help with today's chat. Thank you for sharing your time and your expertise with us. And we hope you all have a good holiday weekend. Thank you very much.
Thank you, Ed, for having us.
Thank you, Ed.